Management, right? So if the patient is asymptomatic or only has minor bleeds and their platelets are above 30,000, we observe, okay? That's a classic step 2 question. They'll get you with a patient that has like a platelet count of like 50,000. They're completely asymptomatic and they'll say, what do you want to do? The answer is observe, right? If they're asymptomatic, they're only having minor bleeds and or their platelets are above 30,000, observe. If they're not meeting these criteria, then our first line is going to be steroids. We can do prednisone 1 milligram per kg per day, or we can do dexamethasone 40 milligrams per day times 4 days with a pulse. Or another first line agent is IVIG, which is for more severe thrombocytopenia, so like platelet counts less than 10 or an active bleed. It's often combined with steroids for a more sustained response. So first line are going to be steroids and IVIG if the patient is symptomatic, if the patient has platelets less than 30,000, right? Steroids are usually the go-to, but if it's really severe, that's when we'll think about IVIG. Second line agents are TPO receptor agonists, so that's thrombopoietin agonists, so eltrombopag and romoplistin. We can use rituximab, a CD20 monoclonal antibody, fosfamatinib, which is an oral SYK inhibitor. We have to use shared decision making, right, to make our decision based on the route, the mechanism, the side effects. And then again, your absolute definitive therapy would be splenectomy. And the new guidelines are saying we won't go to a splenectomy until at least 12 to 24 months of trying these drugs first. Splenectomy is the definitive treatment because these antibodies that are attacking the platelets GP2B3A are coming from B cells that are sitting in the spleen. The spleen also makes the macrophages that are eating up some of these platelets. So if we remove the spleen, we remove that problem, all right? Okay. So a brief aside on heparin-induced thrombocytopenia, because I said I would mention it. The pathophys we've already talked about. It's IgG antibodies to the platelet factor 4 heparin complex. The FC receptor mediated platelet activation then leads to overactivation of the platelets. We cause thrombosis, but then we're losing our platelets, so we get thrombocytopenia. All my platelets are being deposited down, so it causes thrombosis, and then all my platelets are being used, so we have thrombocytopenia. So when should you suspect it? When the platelets fall greater than 50% or they nadir to about 20 to 100,000, right? If my platelet counts are less than 20, I'm not thinking HIT, right? HIT usually doesn't drop the platelet counts that low. We should also think about it with timing. If it's 5 to 10 days after heparin or earlier, if the patient has been previously exposed to heparin, that's when we can start thinking about it. And then, do they have signs and symptoms like thrombosis, skin necrosis, or an anaphylactoid reaction after a heparin bolus? We can use this clinical tool called the 4T score, where if the score comes back 4 to 5, there's intermediate risk of heparin-induced thrombocytopenia. If the score is 6 to 8, that's a high risk. So what are my 4Ts? There's thrombocytopenia, right? So we have an over 50% drop or a nadir in platelets between 20 and 100,000. The timing of the platelet fall, so again, 5 to 10 days after initial heparin administration or even earlier if they've had prior heparin. We have thrombosis, and we've excluded other causes of thromboses, and then we've excluded other causes, right? So we've ruled out all other causes. So those are the 4Ts that can help me stratify, do I think this is HIT? Do I think it's something else? So the diagnosis, it's more of a clinical diagnosis, but we can get the platelet factor 4 heparin ELISA, which has a high sensitivity, and we can do the serotonin release assay, which is the gold standard. The problem is those take a little bit for them to come back. So we can absolutely, if we suspect HIT, we could order those. And while I'm waiting for them, we're going to treat them as if they have HIT, right? While we're waiting for it to come back. So what do we do if we suspect HIT, right? The 4T score comes back as 7. We sent off the platelet factor 4 heparin ELISA and the serotonin release assay. What do? We stop all their heparin, so unfractionated, low molecular weight. We start a non-heparin anticoagulant, something like agatroban, bivalirudin, fondaparinux, or DOAX, and we avoid warfarin until the platelets recover, because there's a risk of skin necrosis. So my overall teaching pearls, right? We always need to exclude pseudothrombocytopenia first, right? That's why we get the repeat CBC and we get the peripheral smear. I look for the platelet clumping. If there's platelet clumping, redraw the CBC, put it into a citrated or heparin-coated tube. Remember, it's the EDTA in the tube that usually causes that clumping. ITP is a diagnosis of exclusion. No splenomegaly, otherwise well, isolated low platelets. If we rule out everything, we rule out drugs, we can make that diagnosis. Remember, if they're symptomatic and or the platelets less than 30,000, we can consider steroids and or IVIG. IVIG is reserved for like really severe. If those fail, we can think about rituximab, the TPO agonist. We can think about TYK inhibitors, and then splenectomy 12 to 24 months after the diagnosis. Your smear is going to be gold, right? Schistocytes lead me towards microangiopathy. Blasts lead me more towards leukemia. Giant platelets, maybe more ITP. In hospitalized patients, you want to think about sepsis, DIC, HIT, certain drugs before we think about more rare causes. And pregnancy, we want to think about gestational thrombocytopenia. We can also think about HELP and preeclampsia as well. If you want to read more, here's where I learned a lot of this on top of all the questions I do and all the other reading. But these are two really solid articles on an approach to a overall approach to thrombocytopenia. So let's do a case to put it all together. Everything you've learned in the last hour. So we've got a 23-year-old female presents to the emergency department due to fatigue and feeling feverish. She has felt fatigue for the past few days and noticed a new fever yesterday. Her mom insisted she get brought to the ED because during a phone call this morning, the patient started speaking in a nonsensical manner. The patient has no relevant past medical history or family medical history. She is currently only taking a multivitamin and has a copper IUD that was placed uneventfully 2 years ago. A routine CBC and BMP are drawn and are notable for the following lab values. Her hemoglobin is 8.5. Her baseline is around 14, so that's a pretty decent drop. Her hematocrit is 25.5, also low. MCV is 85, so that puts her normocytic. Her white blood cell count is 7.2, so that's normal. Her platelet count is 20,000, so pretty low. Sodium and potassium are normal. Chloride and bicarb are normal. Her BUN is slightly elevated. Her creatinine is slightly elevated. Physical exam is notable for oral pharyngeal petechiae and a few scattered purpura on all four extremities. Her sclera are pale. There's no rash noted. She has no hepatomegaly or splenomegaly. The patient's hemodynamically stable with a blood pressure of 125/76, heart rate of 98, and a temperature of 101.8, so a little bit feverish. She denies any headache, chest pain, diarrhea, and abdominal pain. A neurological exam is within normal limits. However, the patient does state that she thinks that the year is 2002. All right. A repeat CBC is drawn and a peripheral smear is ordered, and it's shown on the next slide. So here is what we got on the peripheral smear, and we redid the CBC and the BMP, and it showed the same numbers on the labs. So here's what we got on the peripheral smear. I want you, based on this, what is your differential diagnosis based on what we see on the smear? How does the patient's presentation labs and history help us further narrow down this differential? And then what, if you want to order anything else, is there any other labs or imaging we should draw at this moment? So pause your screen, think about it, and then we'll discuss. So this patient has bicytopenia with quite a significant decline in both hemoglobin and platelets. She has schistocytes on the peripheral smear, right? So if we go back, right, schistocyte, right, we can see these helmet cells, which further narrows down the differential to more of this thrombotic microangiopathy type picture. So we can think about DIC, TTP, HUS, HELP, malignant hypertension, and drug-induced. So based on that peripheral smear and kind of how the patient is presenting, we decide to order a beta HCG. We order our coagulation and DIC panel. We order LDH, haptoglobin, reticulocyte count. We do liver-associated enzymes with bilirubin. We order complement and atom TS13 levels. All right. So those would be all things I would really want to get in this patient right off the bat. So coming back, The DIC panel is all within normal limits other than her known thrombocytopenia to 20,000. Her beta HCG is negative. Her LDH is 2,000, which is pretty high. Haptoglobin is undetectable. Her indirect bilirubin is 3, which is high. Reticulocyte count is 7%, which is high. ALT, AST, ALK phos within normal limits. Her C3 and C4 within normal limits. And that ADAM TS13 is pending because that takes a few days to come back. So, based on all this, right, we have a 23-year-old female presenting with fever and maybe some neurological problems. She has bicytopenia with low hemoglobin and platelets to 20,000. We have a peripheral smear that shows schistocytes. And then we have labs that further confirm hemolytic anemia, right? Elevated LDH, low haptoglobin, elevated indirect bilirubin, elevated reticulocyte count. Her liver enzymes are normal. She's not pregnant. The coagulation panel was normal, so the coagulation factors aren't involved. C3 and C4 are within normal limits, so it's not like an atypical hemolytic uremic syndrome. And we've got this Adams TS13 pending. So what's your leading diagnosis, and what should we do for our patient right now? So all this together, you have to be very suspicious about TTP, right? The reason I've shown TTP in so many lectures now, one, it's extremely highly tested. Two, if you have any suspicion of TTP, you have to start plasma exchange now, like ASAP. You have to talk to your hematologist oncologist, because if we don't treat it right, it's extremely deadly. So we need to start Plex or plasma exchange ASAP. Plasma exchange is always the right answer. It's always the first step. We can consider using steroids, rituximab, and caplacizumab. Caplacizumab is an anti-von Willebrand factor monoclonal antibody. So those are all kind of second-tier agents. Please watch my MAHA lecture again, another plug for it, where I go into all these way more in depth. You can really impress your attending. There's something called the plasmic score. The plasmic score is kind of like the 4T score that we just talked about for heparin-induced thrombocytopenia. It helps kind of stratify risk of TTP. It's not the best test, but it's something you can easily punch numbers into MD Calc and kind of get a sense. Again, it's more of like clinical gestalt. But this patient had a plasmic score of 7, high-risk group, 72% risk of severe ADAM TS13 deficiency. So we need to start plasma exchange ASAP. This is very concerning for TTP. All right, so that was a lot. We covered all of the quantitative causes of platelet dysfunction or platelet disorders. We talked all about the workup, how to think through everything, right? That literally was how I worked through my patients with thrombocytopenia. I think this was one of the highest yield lectures I could give, one of the most fun lectures I've had putting together. So I really hope it helps you guys. Rewatch it as many times as you need. Again, please go watch my anemia lecture, go watch my MAHA lecture, and it will give you some more context to kind of put this all into your framework. Until next time, please email me, and I'll have another video out for you guys soon.